Warm greetings to everyone. Today, we will be delving into the topic Cementum in periodontics with the presenter Dr. Radhika, Associate Professor from the Department of Periodontics, Chettinad Dental College and Research Institute. These are the various contents which we are going to explore today. Introduction. Cementum is a calcified avascular mesenchymal tissue that forms the outer covering of anatomic root given by Karanga 11th edition. First demonstrated in 1835 by Franke and Raschko, two pupils of Perkenji, begins at the cervical portion of the tooth at the cemental enamel junction and continues to apex. Two main types are cellular and acellular. The acellular is also known as primary cementum, whereas cellular is known as secondary cementum. Both consist of interfibrillar matrix and collagen fibrils. Physical characteristics. Cementum hardness is greater than dentin. It's light yellow in color and lackluster, lighter in color than dentin. However, it may not be distinguished on the basis of color alone. Permeability of cellular cementum is greater than that of acellular cementum. With age, the permeability of cementum decreases. Thickness at cemental enamel junction, that is 20 to 50 micrometer, that is thickest towards the apex, that is 150 to 200 micrometer. Composition of cementum, dry weight basis, 45 to 50% inorganic substance which consists of calcium and phosphate in the form of hydroxyapatite crystals, 50 to 55% organic material and water. Organic matrix of cementum consists of type 1 collagen about 90%, type 3 collagen about 5%, and other non-collagenous proteins. By volume, 45% inorganic, 35% organic, left out 20% by water. Two collagen fibers. Sharpie fibers, that is the extrinsic one, are the embedded portion of the principal fiber of periodontal ligament and formed by fibroblasts. Fibers that belong to cementum matrix, that is the intrinsic one, and produced by cementoblasts. Due to its lower crystallinity of mineral component, cementum has the highest fluoride content, readily decalcifies in the presence of acidic conditions. Non-collagenous Non-collagenous proteins play important role in matrix deposition, initiation and control of mineralization and matrix remodeling. Proteoglycans such as chondroitin sulfate, hyaluronate, heparan sulfate, glycogen, and osteoaderin. Growth factors TGF-beta, bone morphogenetic protein BMP, platelet-derived growth factors, osteoprotein. TGF-beta is the tissue growth factor beta. Cementum-derived growth factor seen exclusively in cementum is an insulin-like molecule, and hence proliferation of gingival fibroblasts and periodontal ligament cells. Classification of cementum into two subtypes. One is acellular cementum, second is the cellular cementum. Acellular cementum is unfortunate because as a living tissue, cells are an integral part. However, some layers do not incorporate cells while other layers do not contain such cell in their lacunae. Acellular is the first to be formed cementum. Sharpie fibers make most of the structure. Formed during root formation before tooth reaches occlusal plane, covers approximately cervical one-third of the root, does not contain any cells, more calcified, formation is slow, arrangement of collagen fibers are more organized. Cellular cementum forms after the eruption of tooth once it reaches occlusal plane. Its formation is also in response to the functional demand. Sharpie fibers occupy a smaller portion, contain cementocytes in lacunae that communicate with each other by canaliculi. Covers apical two-thirds of the root, contains cementocytes. Its deposition is more rapid in nature. Collagen fibers are irregularly arranged in cellular cementum. Schroeder and Page classification in 1986 classify cementum on the basis of location, morphology, histological appearance, such as acellular afibrillar cementum, acellular extrinsic fiber cementum, cellular intrinsic fiber cementum, cellular mixed stratified cementum, intermediate cementum. It's a pictorial diagram showing the various cementum types of classification given by Schroeder and Page. Acellular afibrillar cementum. The fibers are absent, the cells are absent, formed by cementoblast, location at coronal cementum, Thickness is 1 to 15 micrometer. Acellular extrinsic fiber cementum. The fibers densely packed bundle of Sharpie fibers. Cells are absent, formed by fibroblasts and cementoblasts. Location is at cervical third of the root. Thickness is 30 to 230 micrometer approximately. Cellular intrinsic fiber cementum. The cells are present as well as intrinsic fibers are present, formed by cementoblasts. Location, resorption lacunae. Cellular mixed stratified cementum. Fibers, both intrinsic and extrinsic fibers are present. Cells are present, formed by fibroblasts and cementoblasts. Location, apical one-third of the root and percussion. Thickness approximately 100 to 1000 micrometer. Intermediate cementum. Cells show cellular remnants of Hertwig sheath. Location at cemento-dentinal junction. Thickness approximately 10 micrometer. Cementogenesis. Formation of cementum is known as cementogenesis. Cementum formation takes place along the entire root. At the advancing root edge, Hertwig epithelial root sheath, which is derived from the extension of inner and outer enamel epithelium, release enamel proteins. Hertwig epithelial root sheath possibly send inductive message to the ectomesenchymal cells of pulp. These ectomesenchymal cells of pulp now differentiate into odontoblasts and produce a layer of predentin along the inner aspect of Hertwig epithelial root sheath. Once dentin formation is underway, break occurs in Hertwig epithelial root sheath. Therefore, the inner layer of dentinal follicle come in contact with the predentin. Cell of the dental follicle now differentiate into cementoblasts, which are the main cells responsible for cementum formation. Cementoblast inside organic matrix which is uncalcified and called as cementoid tissue or pre-cementum. This is a pictorial diagram of showing the process of cementogenesis. Mineralization. Mineralization begins in the depth of pre-cementum. Fine hydroxyapatite crystals are deposited first between and then within the collagen fibrils by a process that is identical to the mineralization of bone tissue. Jander and Herzeler examined the thickness of cementum on extracted human teeth from individuals of varying ages and concluded that the mean linear rate of cementum deposition on single root tooth is about 3 mm per year, but varying greatly with tooth type, root surface area, and type of cementum being formed. A similar rate has been found for acellular extrinsic fiber cementum in premolars and in non-functioning impacted teeth. The width of the pre-cementum layer is approximately 3 to 5 micrometer. Process of establishing the approximate condition for crystallization and growth of individual crystals in cementum normally are extremely slow and extend over a period of several months. The development of cementum has been subdivided into two stages, pre-functional stage and functional stage. In pre-functional portion of the cementum is formed during root development and is extremely long-lasting process, whereas the functional development of cementum commences when the tooth is about to reach the occlusal level and is associated with the attachment of root to the surrounding bone and continues throughout the life. It is mainly during this stage that adaptive and reparative processes are carried out by the biological responsiveness of cementum. Cementum-associated cells are cementoblasts and cementocytes. Cementoblasts are derived from the dental follicle. Transformation of mesenchymal cells of dental follicle. Cementoprogenitor cells synthesize collagen and protein polysaccharide. These cells have numerous mitochondria, a well-formed Golgi apparatus, a large amount of granular endoplasmic reticulum. Histological observation of area of root resorption has shown that cementoblasts can arise wherever viable dentin is exposed to the soft tissue of periodontal ligament. Induction of cementoblasts from the periodontal ligament cells and apparently take place throughout life as evidenced by physiological area of cemental repair. Cellular turnover among cementoblasts is slow compared with in osteoblasts that line the alveolus. Furthermore, it appears that cementoblasts are capable of altering their rate of cementum deposition. Cementocyte. Cementocytes in lacunae and the channels in which their process extends are called canaliculi. The central cell mass may appear rounded or oval and diameter ranges from 8 to 15 micrometers. The cytoplasm is palely basophilic and the nucleus is centrally located. Cementocytes communicate with each other through a system of anastomosic canaliculi radiating from their body. This is a pictorial image where the cementocytes communicate with each other are shown. Cemento-enamel junction. The junction between the cementum and enamel at the cervical region of the tooth is termed as cemento-enamel junction. Four types of relationship exist. In about 60% cases, cementum overlaps the cervical end of enamel. In approximately 30% of all teeth, cementum meets the cervical end of enamel. In 10% cases, enamel and cementum do not meet, which can cause accentuated sensitivity because of exposed dentin. In about 1.6% of cases, enamel overlaps cementum. This is a pictorial diagram of the various relationships of cemento-enamel junction. Various methods of cemento-enamel junction location. Methods for location of cemento-enamel junction include following two kinds, conventional one and modified. In conventional methods, we have visual, tactile, radiographic. In modified methods, we have Florida probe, interprobe, Jeffcoat probe, Foster-Miller probe, etc. Functions of cementum is first anchorage, adaptation, and later repair and resorption. Anchorage. To furnish a medium for the attachment of collagen fibers that bind the tooth to alveolar bone. Connective tissue attachment to the tooth impossible without cementum. Example, in hypophosphatasia, loosening and premature loss of anterior deciduous teeth occurs. The exfoliated teeth are characterized by an almost total absence of cementum. Adaptation. Continuous deposition of cementum is of functional importance. Cementum is not resorbed under normal conditions. As the most superficial layer of cementum ages, a new layer is deposited that keeps the attachment apparatus intact. Repair. Serves as a major reparative tissue for root surface. Damage to roots such as fractures and resorption can be repaired by the deposition of new cement. Local factors for resorptions are trauma from occlusion, orthodontic tooth movement, pressure from malaligned erupting teeth, cysts and tumors, teeth without functional antagonists, embedded teeth, reimplanted and transplanted tooth, periapical and periodontal disease. Systemic factors such as calcium deficiency, hypothyroidism, hereditary fibrous osteodystrophy, Paget's disease, and third one is the idiopathic. Cementum disruption appears microscopically as bale-like concavity in the root surface. Multinucleated giant cells and large mononuclear macrophages are generally found adjacent to cementum undergoing active resorption. Cementum repair can occur in devitalized as well as in vital teeth. Resorption occurs most commonly in apical third, then in middle third, followed by gingival third. Developmental anomalies associated with cementogenesis are cementicles. They are small globular mass of cementum found in approximately 35% of human roots. These may result from microtrauma when extra stress on sharpie fibers causes a tear in the cementum. May not be always attached to the cementum surface but may be located free in PDL. Are more commonly found in apical and middle third of the root and in root furcation area. May develop from calcified epithelial rest around small speckles of cementum or alveolar bone traumatically displaced into the periodontal ligament from calcified sharpie fibers and from calcified thrombosed vessel within the periodontal ligament. Enamel pearl. If some herpes epithelial root cells remain attached to the forming root surface, they can produce focal deposit of enamel-like structures called enamel pearl. Clinical significance of enamel pearl. They are plaque retentive structures, promote periodontal disease. They look similar to calculus but can't be scaled off. Only grinding will help in elimination. Abnormalities of cementum such as cemental hyperplasia or hypercementosis, cemental aplasia or hypoplasia, ankylosis, Exposure of cementum to oral environment. Exposed in case of gingival recession leading to pocket formation. Permeable to be penetrated by organic substance, inorganic ions and bacteria. It's a pictorial diagram where as the pocket deepens, the collagen fiber gets destroyed, cementum exposed to oral environment. Once it got exposed, collagen remnants of Sharpie fibers undergo degeneration, creating an environment for bacterial penetration. 87% of viable bacteria found in root of periodontal non-carious teeth, thus leading to fragmentation and breakdown of cementum and resulting in the area of necrotic cementum separated from tooth by mass of bacteria. Finally, the bacterial penetration found at the deep as a cemento-dentinal junction. Conclusion: Cementum forms a functional unit which is designed to maintain tooth support, integrity, and protection. Minor non-pathological resorption defects on the root surface are generally reversible and healed by reparative cementum formation. Irreversible damage may occur when the cementum is exposed to the environment of a pocket or oral cavity. Thank you for listening.